Okay, let's go ahead and get started. Let me begin by wishing everyone a very happy and healthy new year. I want to say that the speaker today, Chuck Daly, is someone that I've wanted to hear talk about this particular subject for the last 8 years. So it's a talk that I've been looking forward to for a while. Chuck Daly is a professor of medicine in our Department of Medicine. He's the chief of the Division of Mycobacterial and Respiratory Infections at National Jewish, and also the director of the NTM Center of Excellence at National Jewish Health. Chuck received his BA degree and his MD degree from the University of Mississippi, and then he went to UCSF for his residency, chief residency, and fellowship. He also did his research fellowship at the CVRI, the Center for Cardiovascular Research, and worked there with Phil Hopewell and got involved in research focused on tuberculosis. Throughout his career, he's focused on bronchiectasis, tuberculosis, and non-tuberculous mycobacterial infections. He's been funded by the NIH, the CDC, and industry. I think one of the things that's really notable when you look through his CV is that he's collaborated across the United States and across the world in studying various issues related to bronchiectasis, tuberculosis, and mycobacterial disease. He's focused on the accelerated diagnosis of this disease, the molecular epidemiology, the immune responsiveness, particularly focusing on individuals with HIV, and also the world spread of infections and the effective treatment of mycobacterial disease. He has spoken across the globe in many of these subjects, and it's a pleasure to welcome him to Medical Grand Round. So let's give him a round of applause.
Thank you very much, David. Thanks for that introduction. It's a pleasure to be here. My voice is a little raspy from a recent cold. Hopefully it'll make it through the session. I was asked to pick a topic, and I think this is my most passionate one right now, and that's non-tuberculous mycobacterial infection. And I subtitled this, What's in a Name? And I'm sure anyone in the audience can tell me where this comes from. Romeo and Juliet, and what's it about? What's in a name?
Romeo's last name.
So Romeo was came from a very wealthy and famous family. So what's in a name? That which we call a rose by any other name would smell as sweet. She's telling Romeo that she loves him, not his name. So she's making the point that names are not important. However, I'm going to make the point that in the context of non-tuberculous mycobacteria, names are extremely important. And by name, what I'm really referring to are species and subspecies. This idea of just using the term NTM, non-tuberculous mycobacteria, does somewhat of a disservice to our patients because it kind of lumps them all as if they're all the same, and they're actually quite different. Let me begin. A few conflicts of interest. I was a site investigator for a randomized trial of liposomal amikacin. I'm not specifically going to discuss that, but I also chaired a data monitoring committee for an MDR-TB trial of clofazimine, and these are advisory boards for companies that have products, which I'm very happy, or they're moving products forward for non-tuberculous mycobacteria. So 3 learning objectives. So one thing, I do want you to leave here feeling like you understand epidemiologically what's happening with NTM, at least in the United States, where we'll focus. And I am going to make this very clinically relevant discussion. So I'd also like you to feel very comfortable telling me how you would treat a patient who had pulmonary MAC, and even a little more detail about Mycobacterium abscessus. I want you to be able to explain to me how resistance can impact their outcome. And so we'll spend a fair amount of time because this gets into the issue of what's the name, what's the species. So first, I know we have a very broad group of individuals, some of you who know a lot about NTM and some may not know what NTM are, so we'll start with what are they. A very brief description of the epidemiology because I'd like to set the stage as to why you're here. This is a very important and emerging group of infections. I'm going to just go into very little detail on the clinical presentation and diagnostic approach. And the reason that the diagnostic approach has to be mentioned is that's where the name comes. It's in our laboratories. That's where we speciate or subspeciate the organisms. And then we'll move more into the discussion of treatment and how the species determines how the patient will do. So what are NTM? Well, they come from the genus Mycobacterium. There are now over 170 species, actually 180 as of last week, species of NTM. One of the things we should do is have a test maybe at the end of this and see how many of those you can get. I don't know how many I could get, and I know I would probably misspell most of them. But the two that I know you know in terms of mycobacteria are tuberculosis, Mycobacterium tuberculosis, and leprae. All the others we call NTM. Some people will say Mycobacterium ulcerans should also be pulled out separately, but many include it in the NTM category. And in the figure, what you see are the number of species that have been increasing since the 70s to this now almost 180, and probably more than that if you include subspecies. So there's been a dramatic increase in the number of species. And obviously for a clinician, this is very difficult. You get these names that come to you in these reports, you have no idea. Is this a pathogen? Is this not a pathogen? Is this transmissible? Is this not transmissible? So we are really seeing an evolution that's kind of outstripping our ability to implement this into clinical practice and keep up with all these names. The good news is, at least from the lung perspective, there's a fairly narrow list that have caused disease. This is not a full list, but a partial list of those that have been reported to cause lung disease. And they're divided into the classic slowly growing mycobacteria and rapidly growing. Now, rapidly growing, for the patient, when they hear that, sounds very bad. You have a rapidly growing mycobacteria, but they're not really that rapid. The definition is that we see growth on subculture. So not from their sputum, but if you take a culture and sub it, we see growth within 7 days. And the slower growers, they take longer than 7 days. But these are the traditional ways that we've divided them up. And you see names, I'm sure many of those you've never seen before, but a few you do recognize. And I'm going to bold the two that we're going to focus on because these are by far the most common cause of lung disease. The MAC, Mycobacterium avium complex, the ones that are bolded are the three most common species, avium, chimera, and intracellular. And then the Mycobacterium abscessus complex, which includes three subspecies, abscessus, Belledii, and Massiliense. And I know for many of you who do not practice in this area, you may not have heard of some of these, but these are the most common causes of lung disease from these two different complexes. So let's set the stage here in terms of what's happening. So this slide, these data were just put together by a former fellow, Ted Maris, who's at the University of Toronto. And I like these studies for North America because they're population-based studies. So for a non-reportable disease like NTM, it's hard to get good data. But from a population-based segment, we can at least get some idea of what's happening. So what you see, the first study was 4 HMOs in the U.S., for which they were able to use data to come up with rates. The second study was Medicare data, so this was ICD-9 coded Medicare data. And the only bias here that you need to recognize is these are people who are 65 and older, so an older population. Ted Maris from Ontario, they get over 90% of the cultures from the entire province go to one provincial laboratory. So they have very strong microbiology capture in that study. And then Kevin Winthrop, another former fellow from Oregon, looked at statewide data over a short period of time. If you look at the other periods, you can see these are decade-long in some cases, whereas in Oregon it was much shorter. So now you see 2 columns, the frequency. There's the isolation frequency and there's the disease. If I was talking about TB, we would have 1 column because isolation and disease are the same, right? You grow 1 colony of Mycobacterium TB, that's a reportable case of TB. Unfortunately, with NTM, that's not the case because just because you do grow it doesn't mean it's harming you. So the isolation frequency just means how many positive cultures over the time period. The disease frequency means how many of those met what's called the ATS definition, American Thoracic Society definition, and IDSA definition for disease. We'll look at that in just a moment. But as you can see, that about half the people who grew it once were felt to have disease, at least once. So the isolation frequency in the U.S. for the integrated healthcare systems was about 12 per 100,000. About half of those had disease, 0.5 per 100,000. If you look at an older population, look at the disease frequency in those who are 65 and older, 47 per 100,000. That's an extraordinary disease frequency, and we're going to compare it to TB in a moment. In Ontario, Canada, it was about 10 per 100,000. Oregon, which we always thought was a low-risk state, was about 6 per 100,000. So how do we put this into context? Well, most of us think about maybe we should compare it to TB, which is, I'll show you in a moment, but it's about 3 to 4 per 100,000. So the rate of disease by NTM in these various populations is almost twice that of TB in Canada and the United States. So this is a significant disease that has now eclipsed TB as the most common mycobacterial disease. Now, the other reason these are good studies, they had trend data. So what's happening over time? If you look at the trend data from the healthcare, integrated healthcare systems, it was about 2.6, 2.9% per year increase over from 1994 to 2006. If you look at the Medicare population, 8.5% per year. In Ontario province, 10% per year increase. There are very few diseases that you can come up with that are increasing at that frequency. That is a striking increase. And then about 2% in Oregon. So we have something that's common and that is increasing at fairly dramatic rates over consistently now in several studies over a decade and continuing to go up. So that's TB rate in the U.S., 3 per 100,000. So just kind of keep that in mind as a reference. Because this is not reportable, people say, well, how many cases do we have? And, well, we have to guesstimate that. In 2010, the NIH estimated there were 86,000 cases. And if that 8% per year or more increase was correct, they guessed that it would be about 180,000 by 2014. Now, we don't know if that's true or not, but that's what they estimated based on that Medicare database as well as some statistical modeling. And those cases are not spread equally. You can see throughout the states, if you look at the number of cases, with the darkest color being over 3,000, we can see some of the more populous states like California, Texas, Florida, New York, Pennsylvania. They have a lot of cases of NTM. There are other areas of the U.S. that have very few cases, but they also have very few people. So maybe it's better to look at a rate than just the number. So here are the rates. But as you can see, they tend to be higher except for a couple of instances around water. They're coastal or up by the Great Lakes. And why is that important? Where do these things come from? They come from our environment. They come from water and they come from soil. So there are several studies now that have shown hot spots in the U.S. and in Europe tend to be around water. So why are they increasing? This is a very important question. So these are kind of some of the things I just broke down and thought about this along with a lot of friends. Exposure. We have more exposure to aerosols than we used to have 50 years ago. I mean, we take showers once, twice, 3 times a day. We take them at the club. We take them at work. We take them at home. So a lot of aerosol exposure. We've changed our plumbing. We went from copper plumbing, which does not support biofilm, to PVC, which very much supports the development of biofilm. These organisms produce biofilm so they can survive in our plumbing systems. We also lowered our hot water temperatures to prevent scalding, to save energy, and that has also allowed an increase. We know that if you increase your hot water temperature, the concentration goes down. And we know there are other countries that tend to run higher water temperatures, and they have lower concentrations in their water. So probably things we've done to our environment. Yes, it's not just the environment. We would all agree there's a finding bias or diagnostic bias because we're looking harder for these things. We're doing CAT scans if you sneeze. So the CAT scan comes back, says tree and bud nodularity. Someone sends a sputum, so we find a new case. So there's certainly that is occurring. Host factors, we have an aging population. I showed you the rate in the older individuals, and the Medicare study was much higher than other rates. We have more immunosuppressed patients who are more susceptible. And there's this interesting phenomenon that may or may not be real, which is decreasing cross-immunity to TB. If our rates now are 3 per 100,000 for TB, we have very little TB infection now. It's less than 1% in most U.S.-born populations, so it's very low. So with that in mind, we don't have an immune response to mycobacteria anymore. And maybe that's why these things that we've eaten and been drinking and showering in are now starting to cause harm. Maybe we've lost some degree of cross-immunity. We published a systematic review where we actually showed that as TB rates were going down in 22 countries, NTM rates were going up in over 90% of those countries. So at least from an ecological perspective, there were two epidemics and those curves were crossing. And then the organism, this is something that we're very interested in, but we haven't paid a lot of attention to the organism, but the rest of what I discussed today will be mainly focusing on the organism. So how do patients present? So these are the two classic presentations: nodular bronchiectatic disease with right middle lobe lingular bronchiectasis, and fibrocavitary, which looks like TB. It's upper lobe. They tend to occur in different individuals. The nodular bronchiectatic disease is typically in women, non-smokers, whereas the fibrocavitary is typically in men, smokers. There's a lot of overlap. Having just said that, there's definitely a lot of overlap with this. But we're also seeing now a lot of extrapulmonary disease. Most of this is nosocomial, and it's what will probably lead to this being made a reportable disease, but mainly extrapulmonary. Because most of these are nosocomial. They're related to procedures that have been done, steroid injections, things like that. And we should be able to pick up outbreaks in hospitals if it was reportable. These are all our patients. So one that you see with the lesion on her cheek, she had her wisdom tooth removed, and Mycobacterium abscessus came burrowing out through her cheek. The other person with a hand infection, they had a steroid injection for a trigger finger. And it became very swollen, and after months of treating it with every known antibiotic, they sent the right culture, and she had Mycobacterium avium complex in her hand. And the final one, I know that's hard to tell what that is, but that's her lower extremity. Both lower extremities look like this. And so she's got multiple ulcerations on her lower extremities. So what's one of the questions you would ask someone, a woman who has lower extremity ulcerations? Have you had a pedicure? She had a pedicure. So they almost amputated both her legs. But we cured, believe it or not, we cured her of this, but it took a lot of effort to do so. So pedicure, it's called pedicure furunculosis or salon furunculosis. And that was Mycobacterium abscessus. Okay. So the hardest part of this is the beginning of this algorithm is you have to think about it. And particularly when it's an extrapulmonary site, people don't think about mycobacteria, but that's what we have to do. We collect the specimens, we do our standard microscopy, we recommend cultures in liquid and solid media. Most laboratories in the U.S. do not do that, probably 90+%. They do liquid only. And then we have to tell it what's its name. That's called identification, speciation. And most laboratories in the U.S. cannot provide the names. And that's a problem for a clinician, and that's what I'm going to argue today, is it's a huge problem for the patient. If we can't treat the right organism, if we don't give them the right name. The only way to do that today is through sequencing methodologies. So with sequencing, we can separate these into clinically important species and clinically important, believe it or not, subspecies, in which their treatment outcome differs based on which organism it is. So we have to get past this idea that we're going to use cheap methods because they're not helping the clinician and they're not helping the patient. So who do we treat? So I said this before, that with TB, you grow one colony, you're a reportable case, and I start you on the same 4 drugs if you grew 100 colonies. It's not the same here. So as a clinician, we suffer literally in clinic every day trying to make a decision, am I going to treat this patient? So these are the criteria that were developed by the American Thoracic Society and the IDSA. They're clinical criteria, radiographic, and bacteriologic. So we assume that the patient has symptoms, that they have a radiograph like one of the ones I showed you, but ultimately it's a bacteriologic diagnosis. And we require 2 or more positive sputum cultures. The definition does accept one positive bronch culture. I don't. I would not treat someone with a single positive bronch culture. I want to get multiple cultures over time. But these are the current definitions. And I know as a clinician, people go, okay, if they meet this definition, then let's start treatment. It's not that easy because not everyone who meets definition will progress. These are 3 studies, 2 of which we were involved in, that give us some idea what happens if you grow a mycobacteria, a non-tuberculous mycobacteria. The first was with a collaboration, a very productive collaboration that I have with individuals at Samsung Medical Center in Seoul. So in this study, 14% of people who grew MAC at least once progressed over 16 months. So the majority, at least in a year, did not progress. So we know just growing it does not say this patient is going to progress and that this patient will require therapy. But 16 months is not that long. The second study, Stacy Martignano at Children's, with our CF patients, showed that 38% of CF patients who are at very, very high risk of developing pulmonary NTM, in the same category with 1 or more positive cultures, they progressed over a much longer time now, 4 years. So even a very high-risk population does not necessarily progress. The definition that I told you from ATS used the third bullet. This was a study published in '91 from Japan. And here, 98% of people who had 2 or more positive cultures progressed. But the devil's in the details. So in the first bullet point, those were all patients with nodular bronchiectatic disease and no cavitation. The second bullet point was CF patients, some who did have cavitation. The third bullet point, where everyone in that study was sick enough that they had been hospitalized for at least 6 months. So they had very extensive disease, cavitary disease, smear-positive disease. So the definition that is in our current guidelines is using that third bullet point, but most of the patients we see don't fit that category. So we need to refine this to help clinicians figure out who is likely to progress, what are the predictors of that. So here's what we do in clinic. I look at the patient and I go, do you have an increased susceptibility? Do you have CF? Do you have alpha-1 antitrypsin deficiency? Something that suggests to me that you're not going to be able to fight this infection. Do you have symptoms? If you don't have symptoms, I can give you symptoms, right? I can give you 3 to 4 antibiotics and you're going to be very miserable. So I can make someone symptomatic much more likely to complete therapy than someone who's not symptomatic. Probably the most important thing is the radiograph, because if you see cavitation, that's destruction of the lung. And cavitation has been shown now in multiple studies to be correlated with progression. The next part is the organism, and this is where in the 1997 guidelines, we frankly did not, and 2007 guidelines, we did not really address the organism. We just said they're all the same. Use the same definition for disease. We know that is completely wrong. And we're struggling with the revision of those guidelines and how to address this. But what we do know, the species matters. The name matters. And we'll move now into 2 examples of those species. The bacteriologic load matters, and ultimately, the goals of treatment matter. With TB, the goal of treatment is what? If you see someone with TB and you start therapy, what's the plan? Cure, right? It's 100. You want to cure them. It is not the same here. So sometimes it's not cure. Maybe all we're going to get is bacteriologic conversion. Maybe we'll get relief of symptoms, or their cough, or their shortness of breath, or hemoptysis, and maybe we'll prevent progression. So this is kind of the way we look at our patients every day. Who are you? What organism? How much do you have? And what are the goals of therapy? So let's talk about how can we then look at the organisms that we see and determine whether it matters which species you have or which subspecies. So these are 4 that I'll just summarize for MAC and abscessus. One is maybe where you get it from and how you get it. Does that vary between the different species? Pathogenicity. What if you get infected with certain species or subspecies? Are you more or less likely to progress? Same for clinical presentation. And ultimately, where I think we have the most data, it relates to treatment outcomes. Does it matter what you grow? So this is a patient, a 35-year-old woman from Florida. She had a cough for several weeks. I don't know how well it's projecting. Anybody see anything abnormal? Mycobacterial people, where do we look? Top, up. She's got a right upper lobe, looks like cavity. And she had a CT scan, and absolutely, she had more than one cavity. So they did the right thing. They treated her for TB because she was smear positive, and they're waiting to see what grows. But what grew? Not TB. She grew MAC. Now, this does not look like the CT of the Lady Windermere, right? So she's not a Lady Windermere. She didn't smoke. So she's got more of a fibrocavitary appearance than and this is what I said earlier. There's tremendous overlap in how our patients present. She had MAC, progressive MAC. But what is MAC? What does it stand for? Mycobacterium avium? Okay. So does that mean there are 2 species? I showed you 3. There are about 10 species of MAC. The 3 that Chimera, Intracellular, and avium are the most common, but there are others. There's Temanense, Yonganense. All of these can cause disease. We see them at National Jewish. They're in people's lungs. They're in their skin, causing infection. So MAC is not what you thought. The old term, I call it old term. Some of you will take issue with that. MAI. There is no MAI anymore. That's when it was only A and I. But now we've got 10 species. So Mycobacterium avium complex, that's probably wrong. What we should be thinking about is should we just tell what species is infecting the patient? Instead of saying you have MAC, you have avium. Instead of saying you have MAC, you have intracellular. But the only reason we'll do that is if we find some clinical reason to show it's important. And most laboratories in the U.S. cannot identify Chimera. They call it intracellular because they're not using sequencing. But when they go to their intracellularies and start to sequence, they find that some of them are Chimera. They are not intracellular. Now, why does that matter? Well, where does avium come from? Not birds. Water. Where does Chimera come from? Water. Where does intracellular come from? Not water. It's soil-based. So if you're going to tell your patient, don't garden anymore, maybe you should know what species they have. But where are they getting infected from? So this level of detail is starting to change the way we think. Just knowing the species can tell us maybe where they're getting it from. What about pathogenesis? So there are 2 studies. The first that we were involved in with our group at Samsung, Wenjin Go, and then Boyle at Northwestern. This is looking at predictors of progression in people who had positive cultures who were followed off of treatment for a period of time. I mentioned to you that burden of disease is a progressor. So both of these studies show that if you were smear positive and had fibrocavitary or extensive disease, you were more likely to progress. Any NTM clinician could have told you that. But what they did that no one has done is they actually speciated and looked at the organisms. Now, they didn't have Chimera in Samsung, so they only compared intracellular to avium. But people who were infected with intracellular were more likely to progress than those with avium. They did have Chimera at Northwestern, and again showed intracellular was more likely to predict progression, and avium was more likely to predict progression compared to Chimera. So in these studies, they're not small studies. In this field, 500 patients is a huge study. But they're showing that maybe it matters which species. So when you talk to your patient, am I going to be treating you? It's all based really on, are they going to progress or not? They also looked in both of these studies then about those patients who did present. At the time of presentation, how extensive was the disease? And I bolded and will show you here that it was intracellular in all of these categories. People who had intracellular had more advanced clinical and radiographic disease. They had more cough, more sputum production, more weight loss. And I think it's impressive across 2 countries, different methodologies, that this same kind of feeling is that intracellular is worse than avium and worse than Chimera. So what about treatment? So first, how do we treat avium? If you get MAC, whichever of those species it is, because today you're not going to know. They're going to tell you it's M. avium complex. You may get the information if it's avium or it's intracellular. You probably in most settings will not hear that it's Chimera. That's changing. But you'll know at least it's one of the MAC species. What you want to know is it susceptible to the macrolides? Because if it's susceptible to the macrolides, then you move down the algorithm and you look to see if they have cavitation. If they have cavitation, we give them a daily 3-drug regimen, a macrolide, rifamycin, and ethambutol. But if they don't have cavitation, they have the nodular bronchiectatic form, we actually usually treat them 3 times a week. If they do have resistance to the macrolides, you can't use the macrolide. It doesn't work, and there's a study showing if you continued it, it did not improve outcomes. So we stopped the macrolide. Now we have to find another drug. And this is kind of our list of other drugs. We don't have many. Clofazimine, we use a lot of clofazimine at National Jewish, an old leprosy medicine, still used for leprosy. Moxifloxacin, ciprofloxacin. Bedaquiline is a multi-drug resistant TB drug, which has activity against most mycobacteria. Inhaled amikacin, and any other drug that you can think of or I can think of that we can show some activity. If they have macrolide resistance, or they have cavitation, we usually add intravenous amikacin. So for many of you who are going like, wow, this is complicated. You're having to put a PICC line in, you're given IV amikacin with its inherent toxicities, you're given these oral drugs, and yes, it is complicated. These are hard to treat infections. So what happens when you do that? If they're macrolide susceptible, they have non-cavitary disease, turns out 80% will convert. You will get culture conversion up to a year. We don't have a lot of data beyond that. Cavitary disease, not surprisingly, they have lung destruction. Their cure rates are lower. They vary between 50 and 80%. But here's the shocker. If they have macrolide-resistant disease and you don't resect the lung and you don't give them IV aminoglycoside, culture conversion, 5%. Rick was just asking me, are we seeing more macrolide resistance because it's being used so much in other lung diseases? And the concern is that we're going to get more cases of macrolide resistance because when we do, it becomes really almost incurable unless you do something like surgical resection, give a prolonged aminoglycoside. In this one study that looked at this over 6 months of IV or IM aminoglycoside, then you can get the culture conversion back up to 80%. But at what cost to the patient, to do that, to get it? So we don't want to develop macrolide resistance. Then, okay, now you think you've cured them. Now what happens? Well, they can recur. So 3 studies, one from Texas, one from the same one I mentioned before from Chicago, and one again that we did with colleagues in Samsung. Sizable studies for this field. Microbiologic recurrence, meaning they had converted and now they are positive again. 50% in Texas. Half of their cases they thought they had cured came back and had a positive culture, usually within the first year. At Northwestern, a quarter of theirs came back, and a similar number at Samsung. Now, you go, they recurred, but is that because they failed therapy, or did they go back to their environment and get reinfected again? So these studies used either pulse field electrophoresis or RET-PCR, a molecular-based way to genotype or fingerprint. 75% were considered new infection in Texas. 75% they think they cured, but they went back out and got it again. And in Northwestern, it was 50%, and in Samsung, it was 74%. So this is another element. That doesn't matter which species you have. Well, Boyle looked at this too, from Northwestern, looking at predictors of basically, I would call it, they called it clinical relapse reinfection. I would say it's recurrence, because they couldn't distinguish very well which one in this cohort. But what they did is they looked at the organism as a predictor of recurrence. And they did again show, not what we thought they were going to show. We thought it would be intracellularly, right? Because that was the one that was more likely to progress, more likely to cause cavitation. But in this case, it was the water organisms. And maybe that's why, because much more likely to get exposed to contaminated water after a cure and get an avium or chimera than soil. Well, we don't know right now. But they were the first to show that they could find a microbe, the species might have predicted the risk of recurrence. So I'm going to summarize MAC and then finish with abscesses. So acquisition, yes, depends on the species. Pathogenicity, clinical presentation, depends on the species. It looks like intracellular is more pathogenic than the others. And perhaps, and I'm not convinced of this, of the recurrence with the avium and chimera. But if we don't start speciating, we're never going to answer these questions. We can't call it MAC anymore. So the second then is my abscessus case. This is a 68-year-old woman with chronic cough and fatigue, and you can see multiple cavities here. She was in New York. They did the right thing, said, You're going on directly observed therapy. You're going to be isolated at home until we know what this is. They assumed that it was going to be TB. She grew MAC and abscesses. We treated her for her MAC and abscesses. So how many drugs would that be? It's like 7 drugs. It's like XDR TB. We cured her MAC. We never cured her abscesses. She died about 8 years after this of progressive abscesses despite continuous intravenous therapy for that entire time. We couldn't stop it. So abscessus is a bad bug. It was actually first identified in soft tissue because it's very prone to do that, as I showed you earlier in those extrapulmonary cases. It was isolated from this individual's knee and their buttocks because they had some sinus tracts moving up their buttocks. It's probably the second or third most common cause of a lung disease from NTM. It's surpassed Kansasii, at least in the U.S. And the reason it's so difficult, it's resistant to most antimicrobials. It's a highly resistant organism. Now, one of the things that I think is confusing to everyone is that there's this evolving taxonomy, like what you call this thing. Even though it was discovered in the 50s, it was named in 1992 as Mycobacterium abscessus. In 2006, there was a call based on genomic data to split it into 3 species, Abscessus, Macilliense, and Belledii. There was a naming violation, so the name Macilliense had to be retracted. Now, the organism still existed, but they took the name away, and now they called it Belledii. This is the way some laboratories in the U.S. still report it. They tell the clinician it's Belledii, but it's almost never Belledii. It's usually Macilliense. And that is a huge distinction. In 2013, with my colleagues at Samsung, we did another genomic study, and we felt that these were subspecies. So we called for breaking them back open up to 3 subspecies. 2016, there was another group from the University of Texas and from Italy that said, yes, we agree, formal request to call it subspecies. 2017, another group took us all the way back and said they should be species. So today, there's a lot of discussion about this. Are they subspecies? Are they species? Does it matter? It matters. Why does it matter? It's all based on their resistance. The different species have different types of resistance to the macrolides. So they have something called an ERM gene, and an ERM gene allows for the induction of resistance in the organism in the presence of the macrolide. So just to run you through this. So if they have an ERM gene, and this organism is called ERM41, if you do a 3-day drug susceptibility testing, which is what most laboratories do, it will come back susceptible. All right, so you're happy. It says it's susceptible to azithromycin or clarithromycin in this case. If you hold on to that and culture it for 14 days, now it's resistant because that ERM gene was turned on and upregulated, and it has inducible resistance. Now, the 2 species that usually do this are Abscessus and Belledii, of those 3 subspecies. So what does that mean to you, the clinician? Well, you could use the macrolide. It might have anti-inflammatory properties, but don't count it as killing that organism because it's resistant now, only in the presence of the macrolide. You take the macrolide away and reculture it, it'll show it's susceptible, unless you continue the exposure. So this is a problem for us in managing these patients. Now, there are some organisms that have a dysfunctional ERM gene. The gene is there, but it's truncated, and it's non-functional. So then you do the 3-day incubation. It says susceptible. And because it's not functioning, it doesn't induce resistance. So at day 14, it's still susceptible. And you're like, yes, that's what I was hoping for, because that's a susceptible strain. You can use the macrolide, and I'm going to show you it's going to work. And then there's what is called constitutive or mutational resistance, and that's a totally different mechanism. That is a point mutation in the 23S ribosomal RNA, and that just makes it pan-resistant. It's not going to work. Don't use it. So this is what we're dealing with when we talk about speciation, because, look, it depends on the species. You need to know this information. So you say, well, how often am I going to run into these silly things? I hear abscessus, but what about these other subspecies? These are studies from the U.S., Netherlands, and France, but if you'll notice, most are from Asia. Let's focus on Macilliense among these 3 subspecies. You can see that in the U.S. and Europe, it's about a quarter of our isolates from Macilliense, so unfortunately, most are abscessus. We do have Belledii, but Belledii has a functional ERM gene, so it acts like abscessus, so it's bad. Look at, though, if you're going to get one of these go-to South Korea, because you'll get Massiliense, which is half of their abscessus is Massiliense. I just saw yesterday a Korean gentleman, lives in Colorado, and he's got Massiliense. And I said, have you been traveling back to Korea? Yeah. I go, what do you do when you go there? I said, you get in the saunas when you go there, in the tubs? He goes, oh, yeah. I think he's probably lucky that he got infected there as opposed to here, because Massiliense is the one that has a non-functional ERM gene, and the macrolides work. So we'll look at treatment in just a moment, but this is something that I also have to mention. I talked about acquisition of infection with the MAC organisms. What about abscessus? There are now 3, quote, outbreaks of Mycobacterium abscessus, mostly subspecies Massiliense. This is person-to-person transmission of NTM. We've told you that doesn't happen. But all of these were CF patients to CF patients. So maybe highly susceptible individual to highly susceptible individual in the right setting, we may be seeing transmission. And 2 of these were whole genome sequence, very, very similar strains, less than 20 SNP difference in the strains between patients. Even been able to find the same strains in different countries. So we're concerned that there may be some difference, because almost all of the transmission events have been Massiliense. There was abscessus, but most have been Massiliense, suggesting it may be more likely to be transmitted. So let's talk about the outcomes. So treatment of abscessus. I started MAC with saying you need to know macrolide resistance, because it's important in your treatment decision, and it's the same here. But here we really want to know, do they have a functional ERM gene? If they do, it's usually abscessus or Bellettii. In that setting, you can give them the macrolide, but don't count it, because it's probably not working in the setting of inducible resistance. We're going to try to find 2 or more other drugs, usually intravenous amikacin. We give this intensive phase for about 2 months, but sometimes 10 years, depending on the severity of disease. And then we move to more of an inhaled oral regimen. If they're lucky enough to have a non-functional ERM gene, usually means Massiliense, now we can use the macrolide. We have 1 more oral drug and less other drugs we have to look for. The other drugs are often intravenous drugs like the carbapenem, sulfoxetine, tigecycline, some of the same oral drugs that I showed you before, plus linezolid. We try to treat for 12 months beyond culture negativity, but I said earlier there are some patients we can't cure, and as I'll show you, this is a group that we don't use the cure word unless they have which species or subspecies? Massiliense. Here's the data. 4 studies, 1 from our group in Samsung. What they did in all 4 of these studies is they speciated it. So they didn't just call it abscessus. They said it's abscessus subspecies abscessus, or it's abscessus subspecies Massiliense. Now, I'll apologize, the numbers are very small, for all these studies. But look at the difference in clinical outcome. If you look at sputum conversion in Dr. Go's study, 88% converted their cultures if they had Massiliense, 25% if they had abscessus, and it's almost exactly the same all the way down across different settings that we're seeing. If you have Massiliense, you are going to get cured. If you have abscessus, don't tell the patient you're going to cure them, because there's a very, very low chance that you're going to be able to do that. And that's just to highlight the importance of sputum conversion in this disease and how different it is between the species. So you need to know. What do most laboratories tell you? They call it Mycobacterium chelonia abscessus group. They don't even distinguish is it chelonia or abscessus, which also have different ERM gene implications. And if they tell you abscessus, they don't tell you which subspecies it is. This is a problem in this country. We need to get laboratories to react to this. The final bullet point on this is that what if you take people who have Massiliense and should get better, but maybe they got bad treatment? We found 15 patients at Samsung who had initially macrolide susceptible Massiliense. They got treated, they acquired constitutive resistance, so that's very high level, and they acted now just like abscessus. We couldn't cure them. We cured 1 patient, and that patient required surgery. So the macrolide is clearly the issue here. If macrolide susceptibility is present, the patients do well. If it's not, they do not do well. So I'll end with then just summarizing as I did with MAC. So in terms of transmission, we're more concerned right now based on what's been published in the CF population that Massiliense may be more transmissible. We don't understand how, just that it seems to be happening. We don't have good evidence for differences in pathogenicity or clinical presentation, but I think I showed you the numbers are really small. We need much bigger studies to be able to identify that. But what is very clear is that the treatment outcomes vary based on the subspecies in this case. Massiliense, much better than abscessus or Belledii. So just overall summary, I hope what I've shared with you is we have more cases of NTM than we do TB, and that this is increasing at a very high rate. When we diagnose it, we look at the clinical picture, the radiographic picture, but we need to really refocus on the organisms now, and we need to speciate these for diagnostic purposes, for predictive purposes, and ultimately for treatment purposes, because it does impact their outcome. Just some acknowledgments, our NTM Center of Excellence, so we're doing a lot of work now with NTM. Wenjin Go from Samsung, I would like to shout out to him. He's probably one of the most productive NTM scientists in the world. And of course, our Colorado CF Center. So thank you very much.
Thank you, Chuck. That was great. Let's take some questions from the students and trainees. Let me start out with a question.
I have one from Denver Health.
Go ahead.
You presented that Mycobacterium avium species are difficult to treat and have high recurrence. Are there any studies that demonstrate mortality benefit for treatment?
What was the last part?
Are there any studies that demonstrate mortality benefit after treatment?
Okay. So are there any studies that show mortality benefit in treatment? There are studies that, well, first of all, there are studies that show that there is a mortality decrement in people who get this disease to begin with compared to people who don't have it. There are no data right now, except from Ontario province, looking at species, showing that there are different mortality rates based on which species that you have. But beyond Ontario, no. But yes, treatment does decrease mortality. The issue, though, with mortality, you should recognize when you look at the mortality, it's almost not ever due to the mycobacteria. It's usually due to what? COPD, their underlying lung disease. So they do die at a very high rate, but it's usually not the mycobacteria. So what we tell the patient when they're fearful of this is, you probably won't die from your MAC, but you'll die with it. And it's not going to rob you of your quantity of life, it's going to rob you of your quality of life. You're going to be fatigued, you're going to be coughing, you may have hemoptysis. So we really try to focus it not so much as this is going to kill you, but this is going to rob you of some of the joy of life.
Chuck, what is, talk a little bit about genetic drift, especially under stress like treatment with antibiotics.
Genetic drift in terms of the organism and how it evolves under that pressure. So, when you expose any microbe, right, to antibiotics, you're changing that environment. You're putting a pressure on it, and that usually will result in increased rates of resistance. And so Rick was asking me this exact question is, are we seeing more macrolide resistance since it's being used everywhere? What's remarkable to us, well, first of all, the answer to that is yes, but not as much as you would think. Why is that? These are lousy drugs. I mean, they're not cidal drugs, so we just don't see a lot of resistance develop in these patients. The largest study on macrolide resistance was from the University of Texas, which is, like us, a center, and they had very few, over a decade, they had very few cases. So it turns out it's kind of hard to develop resistance. The second problem here with trying to study this idea of what happens over time is that there's no good correlation between drug susceptibility tests, meaning a phenotypic assessment, and clinical outcome, except for amikacin and the macrolides. But all these other drugs we use, there's a lot of variation, so it's not very reproducible. We're doing a study, which you know, in the CF population under Jerry Nick's leadership. So we're doing whole genome sequencing in all positive cultures from CF patients from across the U.S. Every species. As long as they send it to us, we're sequencing them. So we now have done whole genome sequencing longitudinally so that we can get exactly this question. How do these things change, whether they have antibiotic pressure or not? I would say to date we don't have a lot of analyzed data, but we're showing that it depends on the species. Some of the species seem like rock solid. They just don't change, but there's more variation than others. And so probably it's still going to come back. only a creep, it's only going up, but not totally resistant, then perhaps within the cell you're still getting activity. That is probably true. But when you look at the specific mutations that confer macrolide resistance that I'm referring to, that is a big jump in MIC. That is not one that you're going to overcome by increasing concentration for a second. There are other drugs like the aminoglycosides where that is in fact true. The aminoglycosides, we now have evidence, clinical trial evidence, that you see activity from inhaled amikacin up to an MIC of over 64. Now, your lab's going to tell you it's resistant, much lower than that, but we still see activity. So there's kind of a, yes, it's not as active, but when you get over 64, it's a point mutation. We know what it is. You can amplify it, and then the MIC is 500 and something. It is way too high. So I do think that's important. But the other thing I would also say related to the intracellular, it turns out this is, in pulmonary disease, it's a lot of extracellular organisms too. I mean, you go look at that cavity, it's filled with just sputum, and it's smear positive. So we really need to get in both compartments, probably, which is both intracellular and extracellular to kill pulmonary, particularly cavitary disease.
Curious, though, with the ubiquitous use of macrolides, that you're not seeing developing more resistance over time.
Yeah, well, to be honest, it would be a nice message for us if everyone who took it for 6 months got resistant, then everybody would be paying attention to it. But literally, we have people coming on, to our shock, with cavitary disease, and they're on monotherapy. Like, which clinician would do that? And we're just ready to pick up the phone and go, can you believe you made this person macrolide? And we look and go, oh, they're still susceptible. It's just hard. I think it's because they're not very active agents. I think there were, yeah.
Very nice talk. Can you kind of, so your decision tree regarding surgical intervention, so when do you call in for resection of these lesions?
Yeah, so if you have organisms that you can't cure, you need to think about should you resect those areas. So we call it debulking. As you know, we don't tell the patient we're going to cure them. We look at focality. Do they have focal disease? I usually want to see have they failed treatment some period of time, at least 6 months of treatment before I usually recommend surgery. We consider surgery in every single patient as an option, but we don't usually get there. And maybe 20% of our patients end up having surgery, if that. But for those patients, if you look at our Dr. Mitchell's patients and other series, what you can tell the patient if they have surgery is they're going to convert their cultures to negative. Now, that's not the same as long-term cure, but 80 to 100% of people who've had surgery, Japan, Korea, everywhere that's published it, 80 to 100% convert for the first time. So surgery will change the milieu, and now we feel like once we get the worst part out, where our drugs cannot penetrate into these cavitary fibrotic areas, we get that out, we think we have a better chance. The relapse rate in the study from Dr. Mitchell, a fairly short period of time, was 16%, as opposed to this 50%, 75% recurrence in people who didn't have surgery. We're very interested in pursuing that to try to get an idea in a longer-term fashion, do we change the course of the patient? In a shorter term, we do.
Is there any advantage to earlier surgery rather than a failed course or recurring?
Yeah, so we're actually revising the NTM international guidelines now, and one of our PICO questions is about surgery, and this is one that you can't find data to support one versus the other, unfortunately, not in an evidence-based fashion. Our own experience here, and Dr. Mitchell could speak to this more, is that the higher the bacteriologic load at the time of surgery, the more complications. So we tend to delay it a while to try to get the bacteriologic load down. And so for us, pretty much our standard is on a 3-drug oral regimen, we add intravenous amikacin usually for 6 to 8 weeks before surgery. There was a randomized trial that compared 3 drugs plus streptomycin versus 3 drugs, and the only difference they showed was you converted the culture much faster with the aminoglycoside. So that's why we use that approach. And Dr. Mitchell's numbers and complication rates are amazingly low.
So Chuck, you might have mentioned this in the beginning, but you have patients who have this chronic disease with a fairly low virulence organism. And so, some of the underlying diseases, there's COPD, the drugs don't get there, they can't clear their secretions. But what's the story of their genetic, their immunologic and genetic background? And are there things that you could treat them with to enhance their immune response to the bug?
Yeah, so looking at evidence to support this, it doesn't exist. So there have been 2 randomized placebo-controlled trials of gamma interferon. The first one was inhaled, and it was stopped because of futility. It was industry-sponsored. It was never published because they stopped it. But I was an investigator, so I know the results of that, and it did not work. There was a subcutaneous one for MDR-TB, which was also stopped because of futility and increased hemoptysis in those who were getting the gamma interferon. Now, there are anecdotes. Ronnie Kondos at NYU has had some case series. So, I mean, there's a signal that maybe you can do something with interferon. Beyond interferon, there's really nothing. In fact, the recent BTS guidelines just looked at adjuvants and said nothing works.
Those patients who were treated with interferon were people who had interferon defects or receptor defects, or they were just all comers?
All comers. Yeah, when we met with the company, we told them, you may want to look at their interferon axis in some way to look at who responded versus didn't, and their response was, if only a subsegment respond, we're not developing this drug, so we don't care. Literally, that was their response.
Thanks for the talk, Dr. Daly. I guess it seems clear that if you have cystic fibrosis or other structural lung disease, you'd be at higher risk for getting these infections. But could you say how many patients you see who don't have those risk factors to get these infections? And if you do see a patient like that, should you look for some risk factor like immune deficiency or something that might have predisposed them to getting it?
Yeah, that's a really important question. And I'm going to tell you what I think, and there will be people in this field who do not agree with me. I think almost everyone who gets pulmonary NTM has a susceptibility. And that susceptibility is usually underlying lung disease. Could be silent, a little focus of bronchiectasis they didn't even know they had. They got it when they got, RSV years ago. A smaller number have some immune defect, but those are almost always disseminated. So when you look at the Lady Windermere's, like Steve Holland at NIH made a career looking for the immune defect, and he can't find one. And we really can't find a significant one. Ed Chan has found some defects, but they're not very strong. So I think for pulmonary disease, they usually have a normal immune system. And for almost everyone else, they have some underlying disease. Now, if you get MAC in an area of COPD, ILD, other lung disease, most notably probably bronchiectasis, yeah, it can cause progression of that disease, and it can cause bronchiectasis. But in terms of the chicken-egg argument, which came first, the bronchiectasis or the MAC, in my experience, the bronchiectasis is there first. That's why you and I can drink and swim and live in this, and we don't get it. And if you go to the household, how many people in a household have MAC? It's unbelievably rare that more than one person in a household has MAC. Well, they're smear positive coughing for 10 years. How could that person not get MAC? Because they're not susceptible.
Chuck, thank you very much. That was fantastic.